Hi Ninja Nerds, in this video today we're going to be talking about immobility and how that can affect our patients when we are taking care of them at the bedside. So if you like this video, make sure to give it a thumbs up, comment down below, don't forget to subscribe, and I'm really happy that you're here at Ninja Nerd Nursing, so let's get into this lecture. When we talk about immobility, we're going to be talking about all the different aspects of what happens when our body is not freely or independently moving and we're not able to move our body at will. So with immobility, we want to start thinking about what could put a patient particularly in that state. Is it a patient that went through something? Maybe they had some type of trauma and this is a new type of aspect to their life. Maybe they had a stroke. Okay, maybe they have lots of broken bones or broken ribs. Something else is going on where they're just getting older and aging through life and they're becoming immobile. Maybe something else is going on as well. They're really, really sick. They have something else that is just causing them to not be able to move as freely and as independently as they want. So because of that, we have all these systems that can be affected from that immobility. And we're talking about immobility anything from 3 days or more, right? The body can change pretty rapidly when we aren't moving it. So you want to think about that classic, if you don't use it, you lose it. And that's kind of what we're looking at here. So first, let's talk about the integumentary system, right? Our skin. One of the biggest things that we learn in nursing school about our patients is that they can have skin breakdown, and skin breakdown can happen pretty rapidly. But how does that occur? Well, with immobility, and our skin, we have our body interacting with all different types of surfaces, right? So our skin is going to interact with different surfaces. And because of that, we're going to have different types of ulcers or pressure injuries that can occur. And why does that occur? So let's put down here, pressure injury, right? And why do pressure injuries occur? What's going on? Well, we have our skin diagram here. And we have our epidermis, our dermis, and then our hypodermis. And within there, we have that vascularity, right? Right in here, we can see that. We have the veins and arteries, or the capillary beds, really. The capillary bed that's going to help bring all this perfusion to this area. But when we are interacting with the outside world, so say this is where our bed is, right? And then this is our bone on the inside. We're able to move freely. But when there's compression, so when we're laying in the bed for a long period of time, and this bed is pressing down onto our skin, right? Or we're pressing down onto it. And then our bone is pressing in on as well. We start to get this compression in here, right? This decrease in our perfusion. And because of that, we're causing ischemia to the area. And that's when we have a potential for the breakdown of our skin. And over time, they can cause our pressure injury, right? So our patient is at risk for a pressure injury. They're at risk for a breakdown in their skin. And where can that occur within our body? We have a patient here who's laying supine. We want to start thinking about all the areas that our patient is interacting with, either the outside surface or some other surface that is hard against that skin. So you want to think here like the back of the head, the back of the shoulder, the back of the elbows. We have the coccyx area, the sacral area. We have the back of the heel. If the patient was laying on their side, it could be both knees, right? Any bony prominences, our hips. And all of those are going to be areas that we're going to have to think about when we are assessing our patient. Are they having skin breakdown? And these are the areas we're going to focus in on. So let's review really quickly. If we have outside pressure, right, that outside pressure can cause some type of ischemia. And then that ischemia can cause injury, right, or breakdown. So let's talk about what are some of the nursing interventions we're going to do at the bedside in order to help prevent our patient who is immobile from having skin breakdown. What are those nursing interventions that we are going to do now for these patients that we're hoping to prevent all these skin breakdown, this integumentary breakdown, in order to prevent these pressure injuries? The first goal, right, of our patient that is immobile is to what? Protect the skin, right, or to prevent the breakdown. So what we're looking at here is to prevent the skin breakdown, right? And I use the word breakdown because I'm thinking from all the stages of skin being blanchable to being unblanchable to having an opening to having a stage 4 pressure injury. And we're going to talk about that in a separate video, but for the purposes of this video, what are some interventions that we can do to prevent skin breakdown? The first thing is going to be just to assess the skin, right? Some facilities or policies within your facility might be that you need to do a 2-nurse skin assessment. And you want to make sure that when we're doing this, we're assessing everything from color, the dryness, we're looking at the turgor of all the skin, but we're also looking for those bony prominences and seeing if there's any type of breakdown and what we're going to be looking for. So you're going to be noticing any type of color, right? Is there any color change? Is it blanchable or non-blanchable? You're going to be looking if there's any type of dryness, drainage, and all of these are going to be able to tell us, okay, is there something else going on? Is it something new? Is it something different for this patient? And within nursing, we also have a scale that we can utilize, which is something that we can talk about in a future video in depth, but it's the Braden scale. Basically, this is a scale that we use in order to see if our patient is going to be at risk for breakdown. And it assesses everything from mobility, from their continence and incontinence, to be able to assess their neuro to see if they'd be able to tell us if they're having some pain or irritation within the skin or in areas, or if they have to go to the bathroom. And all that is encapsulated into a scale that we can use called the Braden scale. There's also other interventions that we can use, like the Q2 hour or more or less turned. So with a patient that is immobile and maybe not aware, you want to be turning them every 2 hours or even more often, depending on what's going on with them. And with that Q2 hour, you can also think of your cluster of care. You can also make sure that they are dry, see if they had gone to the bathroom or anything, make sure that the sheets are dry, make sure their linens are dry, make sure the patient is aware. It's also a good time to do the turn if they do have to go to the bathroom, maybe get them up if we can get them up to a commode, or maybe using the bedpan. You also want to make sure that everything is intact, so when you are turning them, you can make sure you're checking the skin at that time, so you're making sure everything is looking good from that side that they were laying on. And then you can also use that, like I said before, if they have to go to the bathroom. So is this a time for them to urinate or go to the bathroom? Okay, what else can we be doing? We also can be using some type of barriers. And when I say barriers, we want to start thinking of things like creams, ointments, or anything else that be prescribed and or used at bedside for our patient to help protect the skin. And then we can also start thinking about all those special devices we can use as well. So you want to start thinking of what the waffle mattress you can use, or an air mattress that they have at the hospitals that allow the patient to have offset pressure. You can also think of any type of special pillow that we can use, or a wedge. You also want to check their ears if they're on oxygen. Make sure that they don't have any breakdown around their ear or they're anywhere on their cheeks or their nose, so you can use all those types of little padding that we can put in. And then we also just want to think about asking the patient what's going on with them. Do they feel anything? Is there something that they would like us to check? There's also the boots we can use, right? They have those special booties for the back of the heel. So I just want you to understand that with immobility, one aspect of immobility can cause a slew of issues just from a patient possibly getting some type of pressure injury that then potentially could get infected, because you want to think about the patient that maybe gets a sacral injury, and that sacral injury is near where feces or urine can come in contact too, and then we have some type of infection that can go on into that type of pressure injury, and then the patient can get ill as well. So this is one aspect of immobility. Let's move on now to respiratory and talk about what can happen with our patient if they're immobile and how their respiratory is affected. Now let's talk about respiratory and how this can be affected by immobility with our patient. So we're going to start thinking about our patient who they're laying in bed, right? They're maybe sleeping, so they're just not taking as deep of a breath anymore, or if the patient is suffering from some type of rib fractures or multiple rib fractures, they have some type of medication on board, or maybe pain medication or slight sedation in order to keep them comfortable. And all of that can contribute to our patient having a decreased drive of respiratory. So they're going to have a decreased inhalation, right? Or they're going to have a decreased deep inhale. Basically, they're not filling their lung into that pleural space as nicely as we would like to. Because remember, we have this pleural space, this pleural cavity that the lung can expand into. And we're not taking that nice deep breath in that's going to fill that whole lung capacity, right? We're not taking that nice long inhale and letting that lung expand all the way down to the bottom of the pleural cavity. Instead, we're having maybe a decreased inhale, so we're not getting that full depth of our breath, right? So this lung over here is not expanding as far. And over time, we keep doing that. We have that decreased inhale, right? That decreased respiratory drive to take that inhale can lead to us being at risk for, so they're at risk for what? Atelectasis. And that atelectasis will then also have our patient have what other issues? A decreased O2, right? They're not getting that decreased perfusion, right, of oxygen and CO2 being brought, oxygen being brought in and CO2 going out. And because of that, they may have an increase of exudate, right, or mucus. So we want to start thinking about, okay, we're not taking that nice deep breath in, we're not really getting that movement and that expansion, so now we're going to have this mucus and it starts building up. And our bronchiole likes to be nice and open, but over time, all of a sudden that mucus will start to build up. And that mucus building up and not moving to where it needs to build can also what? Grow and colonize. And as it takes over that lung, we get what do we call that in the hospital? When you can build up that mucus so far, the patient then can be at risk for pneumonia, right? Or atelectasis. So when we're looking at a patient who is immobile and they're not taking those nice deep breaths in, we start to think about all the things that can occur to them, right? They have a decreased O2 sat, so now they possibly have to be on oxygen. Well, if they're on oxygen, whether it's a nasal cannula or some type of mask, now there's potential for breakdown, because if you think about the Integumentary System, where we just talked about that mask can break down on the face or on the cheeks or on the ear. So what are some nursing interventions that we can do for a patient that we see is going to have a decline in their mobility in order to help prevent this atelectasis, this pneumonia, or any other complications? Well, we're going to assess the lungs, right? We're going to assess our respiratory. And to do that, we're going to listen, right? We're going to look at their O2 sat. And we're going to start assessing our patient. What's going on with them? Do they have any other underlying conditions with the respiratory system? Do they have asthma? Do they have COPD? And then one of the biggest things we want them to do, right, is they have this decreased drive for a nice deep inhale. So what is something that we can give them at bedside in order to make that drive, right? Make them start to think about taking a nice deep breath in. What is this thing right here? What is this thing hopefully you've seen before in the hospital? The incentive spirometer, right? And what is the goal of the incentive spirometer? Inhaling with the incentive spirometer. So we give this to the patient at bedside. We tell them to have a nice seal around this tube here so that they're able to take a nice long inhale. When they take a nice slow long inhale, this indicator here will float up, and hopefully it gets to an area that is going to help out this patient take a nice deep breath in, fill the lungs. But what the best thing is about the incentive spirometer is when the patient does it, they typically cough afterwards, and that's a good thing, right? We have all this mucus buildup, so we're going to want our patient to be able to cough. Why is coughing good? We want them to cough because that's going to help move that mucus. It's going to help move it all around, be able to hopefully spit it out or get it somewhere else so it gets out of the lung and we have that movement of that mucus. So the incentive spirometer is really good for the coughing, and usually we want to tell them to use it 10 times an hour. Now, the old school way was to say, you can use this incentive spirometer for us every time you see commercials. But nowadays everyone watches Netflix, Hulu, whatever else type of service. So because of that, I always tell them, just use it 10 times an hour because you don't really see commercials anymore these days. But this is a really good tool in order to use for our patient at bedside so that we can improve their respiratory and not have any effects of the immobility on their respiratory system, because you want them to take that nice deep inhale and mobilize that mucus. So now let's move on to our elimination category of immobility. Now let's focus on elimination here. We're going to be talking about what's going on with our patient who potentially is immobile and is having some issues with their elimination, right? So when we're talking about elimination, we're talking about genitourinary and we're talking about gastrointestinal. So first, let's focus on the genitourinary. When our patient is having issues with mobility, they may have a decreased drive of going to the bathroom, particularly urinating. And what does that have to do with anything? Genitourinary is our urine, right? Our micturition reflex, or the ability for our body to say, hey, it's time for us to go to the bathroom. So a patient who's immobile may have something going on neurologically where they are immobile because of that, and there also is a downfall in the micturition reflex. There could be something else going on where the patient just is very confused and unaware. Again, medication, sedation, things like that. Or it could just be the fact that this patient is not getting up out of bed. So they're laying flat, they're not getting that reflex going to their brain time they have to pee, so we're having a lot more issues of us saying, I have to go to the bathroom. So we want to start thinking about that decrease in our urinary output. right? And we can think about that because there's a decrease in our micturition reflex. So what we're saying is the urine is filling up in our bladder, and instead of us realizing what's going on, that we have to pee, the patient starts having other issues, right? So they're not having the drive to pee, but they might start saying things like, my belly hurts. Or if they're not able to speak, they're just going to be moaning a lot, maybe clutching at their stomach. So they're going to have things like abdominal pain. Maybe they are having incontinence in the bed. Right? So these are things we're going to be looking at to our patient and saying, what's going on? And the biggest thing that we can do for our nursing interventions is to keep an eye on our patients, keep them safe, making sure that their bladder is working the way it should, asking them if they have to pee, offering moments for them to pee. We go in for bedside care, giving medications, things like that. So with our nursing interventions, the first thing we want to think about, we're urinating, we are eliminating things. We're trying to get waste products out of our body. So whatever goes in must come out. So you want to immediately start thinking the eyes and nose. And remember that we use the NCLEX number of the 2,000 milliliters per day as a goal for a patient. Now that is a standardized goal, just like as a normal patient. If a patient has some other underlying issues, 2,000 might be too much for them. But generically, it's 2,000 per patient. So our nursing intervention, I&O, making sure our patient is getting enough fluid, and then that fluid is also coming out. If our patient is unable to tell us, then we want to do frequent checks, right? We're checking underneath them, seeing if they're wet. We also can do things like a bladder scan, right? We can assess them. If the patient does go pee, we can do a pre and post just to see if we are emptying. We're going to measure the bladder, see how full it is. They're going to urinate, and then we're going to be able to measure it again afterwards, and we're going to be able to see if they even are emptying. Some patients may not know they have to pee, and then you go to bladder scan them, and you're like, their bladder is so full right now, I have no idea how they don't know that they have to pee. Another thing that we can do is, what's the whole problem that this patient is getting into, right? They're becoming immobile, or they are just more, they're less mobile than they would be if they were out of the hospital. What is something we can do? If the patient is able to, let's get them up, right? Let's get them mobile. Let's get them hopefully to the bathroom. If they can't go to the bathroom, let's go to the commode. If it is a male or a female, if you have female urinals, although some hospitals, the urinals that I've seen for female urinals aren't exactly the best, but you can use a urinal at bedside. Having the patient stand sometimes just triggers that, like, oh, I do have to pee, or getting over to the commode and sitting with their pants down, all of a sudden, oh, wait, I do have to pee. And that ability for them to just move a little bit is giving us two things that we need for our patient. Mobility, we're getting up and moving, and then we're also going to be able to urinate. And then when the patient does urinate, remember we can always assess the urine, right? We're looking at the urine and we're thinking of the amount. We're thinking of the color. We're thinking of the odor, right? All of that is going to be able to tell us if something else is going on as well. Similar situation here that's going on with genitourinary is also going on with our gastrointestinal. Patient might have some medications that is decreasing that peristalsis within the bowel. Patient might also not eating as often or not drinking as often, so we have a decrease in that peristalsis as well. So the gastrointestinal, right, we're trying to get feces out of us, we're trying to get waste out of us. And if our bowels is not pushing or using peristalsis in order to get that feces out, that feces is sitting in there, and we are at risk for what? The patient's going to be at risk for constipation. And that constipation can cause what other issues? Irritation within the bowel, and then the patient's going to have other issues with hemorrhoids, further down the line, hopefully not even a rectal prolapse because they're pushing so hard. So a lot of the things with the gastrointestinal is we need to get our patient going. Why? Why aren't they going to the bathroom? Maybe it's a decrease in the peristalsis. So the patient isn't going to the bathroom as often. So now we have a buildup of that waste. That buildup of that waste can also do what? It can cause changes in all of our electrolytes or our levels within our body. So there might be imbalances. right? So what are some things that nursing intervention-wise we can do for a patient who is potentially going to be at risk for constipation because they're not getting up? It's not easy to go to the bathroom. They're kind of out of their element. They're not going into the bathroom. Maybe they're not allowed to get up, right? And I don't know about you guys, but a bedpan is not easy to go to the bathroom in. If you've ever had a patient saying, I can't use that, I can't go to the bathroom in the bedpan, it's a very real thing because they're not sitting up in that normal position or even in any position other than laying flat. And that reflex of trying to go to the bathroom when you're laying flat isn't the same as when you're sitting on the toilet. So what are some things that we can do for a patient? Besides everything that we've talked about so far about them being hydrated and their adequate intake and output, their drive to eat, hopefully the patient is able to eat, we can also think about things like medication, right? Are we able to give them something to go? Maybe they can use some type of stool softener or some type of laxative in order to get them going. What is something else we can do for this patient? We can get them up and get them mobile, right? Get them to the bathroom. Can they go to the commode? That would be great. That's a good test, hopefully, to get them moving. And then what is something else we can do for this patient? Think about the food. We're hopefully getting some intake. We're getting that fluid. We want to increase what? Our fiber within that diet too. And that's something you need to talk to the provider with, talk to dietary with in order to get this patient to hopefully go to the bathroom in a safe and effective way. So now we've talked about the problems with elimination, right? We've talked about the problem with the skin on the outside. We've talked about the breathing. We've talked about elimination. Now let's go on and actually talk about what happens to our body. Like I said before, when you don't use it, you lose it. What happens to our muscle and what happens to our bone. Now we're going to talk about musculoskeletal and how this can be affected when we have a patient who is immobile. So we want to remember that we were talking about the musculoskeletal system. We're talking about the muscles and the bone. And both of those can be affected when we aren't using aren't using those muscles as often. Our bones can also be affected. So the first thing we want to think about is that muscle atrophy, right? Or the breakdown of our muscle. Our muscle isn't going to be working as hard as it normally is, so the muscles start to lose their density. They start to become a little weaker. So that muscle atrophy, when our muscles eventually become weaker, what happens too is that muscle breakdown can start dropping in a lot of other type of substances into our blood, right? So as our muscles break down, we start getting extra imbalances metabolically. And we also have our bones. Our bones aren't being loaded as often. They aren't being moved as often. And those can also be broken down too. So we have bone remodeling in a way that isn't necessarily the way we want it to go. And because of that breakdown, again, we're going to have some type of extra stuff dropping into our body, right? We're going to have our calciums and our potassium, and all of that is going to start changing. And this has to do with our osteoclasts, right? Our osteoclasts are going to be breaking down our bone, right? So when our muscles are becoming weaker, our bones are becoming demineralized, they're getting weaker as well. We're going to have a lot of issues with mobility, right? We already can't move maybe because of something else going on, whether we're really sick, broken ribs, et cetera, et cetera. So now we're going to have also potential for us to become weaker and more fragile. So these nursing interventions that we want to look at here are things that we can do at bedside to help better our patient's movement, and then also with other types of services. So one of the things we can do is immediately, if we can, get this patient to a physical therapy consult. That physical therapy consult is going to allow us to get a baseline of what our patient's mobility and physical movement is going to be, right? So we want them to have physical therapy consult. That's going to help us get a lot of basis of their movement. We also want to think about what we can do for them at bedside, right? We can do range of motion exercises. We can also think about their ADLs, right? For the patient they're doing their activities of daily living. Are they trying to put on a t-shirt? Let's not do everything for them, but see if they can do some of the stuff on their own. And then we also want to think about just, again, getting them mobile. So every time we can get them up, go to the chair for meals, going to the bathroom if we can for elimination, or maybe just brushing our teeth. All of those are little ways that we can get our mobility back. And this is twofold, right? Our patient's gone physical therapy consult, and we also want them to be mobile. Well, maybe this mobility is going to be some type of alteration right now. Maybe they're going to be using a cane, maybe they have to use crutches, right? Maybe they have to use some type of walker. All of those are things that we need to think about in order to get our patient to gain that independence back, or as much as they can of their independence. We want them to be gaining as much as they possibly can within our care. So with our musculoskeletal, you want to start thinking about there's a decrease in the ability to move, but we want to be able to get them back to where we can, or at least get them to an area that we think is going to benefit them in their everyday life outside of the hospital. So we want to start looking at that. We also want to start thinking about what's going on now with cardiovascular. If there's anything you learned in fundamentals of nursing, is that when a patient doesn't move, there are potential for a lot of problems, right? Skin breakdown. But one of the biggest things is that cardiovascular. What happens, right? Our patient has a decrease in cardiovascular, so they're not moving as often, right? So the heart's not pumping as often. So if we have a decrease in that heart rate, we have a potential for the decrease in that cardiac output. This is going back to our anatomy and physiology, right? So with a decrease in that cardiac output, we're not perfusing and we're not pumping as often, right? So if we have a decrease in that perfusion or that circulation, we're going to have what issue? What is going on with our patient who is laying flat? What is the immobility causing? It's causing our stasis of our blood, right? So if we have a stasis of blood that's kind of moving a little slower through all of the blood vessels, and we have that stasis, we are at risk for what? A clot, right? And if we're at risk for a clot, what's the big one that they always talk about? A DVT, a deep vein thrombosis. That's one of the biggest issues with cardiovascular and immobility, is that you can develop a thrombus. You can develop a clot, and that clot can cause other potential issues as well. So when we're looking at a patient with cardiovasculars, there's many nursing interventions that we can do in order to help get the decrease in the risk for clot. One of those is the SCDs, right? The sequential compression devices, or SCUDs, some people call them. We're able to put those on a bedside, and that's going to be able to at least help perfuse those calf muscles, get those lower legs moving some of that blood back up to the heart. Another thing we can do is, again, a common theme is get them mobile, and this can be modified. Maybe they can't get out of bed, right? They're not going to be able to walk, but we can have them do what? Things like ankle pumps. You can have them write their ABCs. You can also have them do leg raises. All of these are going to help this patient at least get some type of mobility, and that mobility of moving the lower legs is going to help with the cardiovascular to prevent some clot formation. And again, this is twofold again with musculoskeletal and PT. What is this patient able to do? Are they going to be able to do ankle pumps? Are they able to follow these directions? These are all things we got to start thinking about with these patients. To prevent clot, what is something else that we can do? We can give them some type of anti-clot formation medication. So some people go in and they get heparin, some hospitals give Lovenox, but some type of medication to also prevent the forming of clot. And then we just want to look at this patient as a whole. What is going on? Are they able to increase their cardiovascular by increasing walking to the bathroom? Are they going to be able to do things like that? So with a patient with immobility, we want to start looking at, can they handle moving, right? Can they handle getting up? And another thing that can occur is what? Patients laying for a long period of time, patients not getting up. And now all of a sudden they're like, yep, it's time to go to the bathroom. I did it earlier with PT, I'm going to do it myself. And they go to get up and they get dizzy. What is that problem called, right? Our orthostatic hypotension. So this is another assessment we need to make sure we're on top of our patient with. Are they able to get up out of bed and still have a normal blood pressure? Are they getting dizzy? So we want to start telling them things like change position slowly. They can do things like dangle their feet, right? Sit on the side of the bed and dangle feet for about 2 minutes before you go. And all of these things are stuff that we can help our patients, we can teach them to do in order to keep them safe. Now let's move into what goes on metabolically and neurologically with these patients, and then we'll wrap up this lecture. Now we're on to our imbalances, our metabolic imbalances. And we kind of touched on this already of what's going on with our patient, but we want to just hit this home really quickly. We're going to have lots of changes in our metabolic imbalances, whether it's problems with elimination, things being broken down, not as much intake, right? So there's all of these different changes, right? Changes in our I's and O's. We're not taking in as much food. And fluid. We're changing in our diet, right? We're changing in our bowel habits. And all of those issues can cause a slew of problems metabolically. We also want to think about neurologically or any type of reflex, right? That micturition reflex, the production of ADH and aldosterone, all of those can change our problems or change our balances within our body. So if the patient has suffered some type of neurological injury, if they are suffering some type of other injury which is causing a secondary neurological problem, they're going to have changes metabolically, right? So we're going to have all of these different types of electrolytes that are going to be imbalanced. And because of that, it's very simple or very basic nursing intervention is to retest, right, their blood work. So we're going to be checking that blood work. That's how we're going to be able to know what's going on with our patient inside as well as what we're seeing outside. Because we know this patient is immobile and we know they're having issues, but how far along are those issues? What are the effects that they are having? So when we're checking blood work, we're saying things like our CBC and our CMP or CMB. These are going to be able to tell us what's going on sick-wise. Do they have any high white blood cells? Do they have any red blood cells that are becoming anemic? And then are we having troubles with our electrolytes, right? What's our potassium doing? What's our calcium doing? What's our magnesium doing? And all of that's going to be able to tell us then how we can possibly see what's going on with the patient, correct that problem, and also correct it in another way. What is some way we can help patients, especially if things are too low or too high? We can give them medications, right? So the medications we can give are going to be able to either decrease or increase the electrolyte depending on which one it is. So are we going to be able to decrease or increase that electrolyte? The whole goal is to get this patient balanced, right? They might need some modifications to food. Or their diet, right? So they might have to be modifying that. They might need modifications to medicine. Maybe the meds that they're on right now were great for when they were at home moving around, but now we're not moving around. The medications aren't doing what they're supposed to do, or they're doing too good of a job. So all of these nursing interventions for the metabolic imbalances are things that we need to focus on for our patient to get them better on a simple level, is to correct them. But we also want to think about how did that change come about? Because we need to correct the change and the cause. So we want to start thinking about what was the cause too. Now let's go on to our neurological or our psychosocial. So remember, we have discussed a little bit of how our patient may have gone into this state. Maybe it was something traumatic, maybe there's something else going on, and we want to assess them neurologically and psychosocial. Neurologically, what we're looking at here is, was there a change in their neuro? So was there a change in the neuro, and how can we assess that, right? So we're going to be able to assess our patient at bedside and see what's going on with them neurologically. Do they know where they are? Do they know why they're here? All the way down through our entire neuro assessment. And this is going to be able to tell us other things, like does the patient know if they have to go to the bathroom? Do they have short-term or long-term memory loss? And that neuro is going to also show itself in other different ways, like is the patient really drowsy, right? Are they confused? Are they able to follow directions? It's a nice big one. Are they going to be able to follow your direction if you do get them up out of bed to finally get them mobile, right? Are you going to be able to walk them through using a walker? Is PT going to be able to show them how to use a walker? And then we also want to use psychosocial. Again, there might be some type of trauma that has gone on with this patient. Maybe they had to go into surgery and their immobility is due to an amputation, right? They had to get an AKA, an above knee amputation, and now all of a sudden they are going to have trouble with moving because they have one part of their leg disappeared. They don't have their any type of prosthetic made yet. So is this patient going to be able to cope with their body as well? So the psychosocial is, how is their coping, right? Do they have support from family and friends? And all of this can play a part in the patient's care and their mobility, right? If the patient is becoming depressed, if they're coming very upset with their situation, then they're not going to maybe want to get out of bed. If they're not getting out of bed, they're becoming more and more immobile. So what are some nursing interventions we can do? Right off the bat, we know we can assess their neuro and their psychosocial, right? See what's going on with them. And these can also be outlets that we can refer them to. We can refer them to other members of our team in order to help, especially with the psychosocial. We also have care teams that we can put them off, so care workers, care managers, anything like that, in order to help them with that changes at home. Because that patient that lost their leg, maybe they have lots of steps at home. That's another thing. So focusing on the neuro and the psychosocial, what is something else that we can do? We want to think about them doing the simplest tasks. Can they do their activities of daily living? Are they going to be able to do those independently at home? Are they able to follow those directions? And are they getting better or worse? We want to constantly be reassessing them in order to see, can this patient start to regain what's going on, right? And we also got to think about what's on board. Does this patient have any medications on board that might be causing them, right? We're giving them lots of pain medication, or we're giving them some type of new medication that could be also causing some type of neurological or psychosocial problem. And the biggest thing here is, can the patient have the ability to follow our commands or follow our directions, and are they able to get that through this coping, right? It's going to be a shock to them if there's something that they came into the hospital and they could do before and now all of a sudden they can't. So this is a big area that kind of always gets overlooked, and I want you to focus on really getting to know that patient and understanding what they're going through. Now let's go into our final portion here. Is we talked about it a little bit, but how do we just increase mobility? How can we get our patient to hopefully move around in our care for them? So let's talk about that now. All right, Ninja Nerds, last thing here to wrap up this lecture is, how can we talk about increasing our patient's mobility? Because what's the biggest thing that our patient is at risk? We talked about all of these different things that this patient can potentially become at risk for, right? Breaking down the integumentary system, the respiratory issues, the elimination issues. But what is the one big thing for a patient that is immobile or has trouble moving independently? What is the biggest thing that they're at risk for? I hope you're screaming it. They are at risk for falls, right? So at risk for falls, right? So we need to think about this patient primarily as immobile, at risk for falls, and then everything else that it can also come with it, because safety is also really important. So when we have a patient who we want to increase mobility, they're at risk for falls, right? And they are becoming maybe more and more immobile. What are some things we can do with this patient? Well, first we want to think about, what was their physical fitness or level before they came in? Was this a patient who ran, 4 or 5 miles a week, and now all of a sudden we aren't getting out of bed? What was going on? So we want to think about their physical level before the hospital, right? Then while they're in here and they're having trouble with mobility, we want to think about that physical therapy consult. Right? And with the physical therapy consult, we're going to get a lot of information about what's going on with this patient. Are we going to be able to get them out of bed using some type of device like a cane, walker? Are we going to be able to maybe transfer to a certain area and then just have them stand, so maybe they can only get in the wheelchair? We can push them over to somewhere and then get them to stand there at the bathroom. So a physical therapy consult is another important aspect. What about what's going on with our patient? We want to increase mobility. We get the physical therapy consult. We kind of know what's going on with them. We just want to think about any comorbidities. Right? So when we have our comorbidities, we're thinking about what's going on. What got them to this state? Are they having issues because they had some type of neurological problem? They had some type of neck injury. They had some type of rib injury. They are very sick, so they're got encephalopathy. They're not able to follow these instructions or these commands that I'm giving them. And then from there, we can start thinking about increasing their mobility. So things like mealtime. Can we just get them over to a chair to sit up and eat? When it's time to maybe go to the bathroom, right? They gotta go to the bathroom. Can we get to the bathroom? Are we gonna use a commode? Right? Are we gonna use a urinal? Are we gonna be able to use a cane, walker, crutch to get to the bathroom? Right. And then we also just want to think about those really basic things. Can we do things in bed? Can we do our range of motion, ankle pumps, leg raises? Are they even able to roll? Can this patient roll themselves side to side? So that are just a couple of things to think about why immobility is so detrimental to our patient, why we need to make sure that our patients are being mobile, that they're able to independently and freely move themselves, and if they can't, what is the whole slew of problems that they could possibly run into while under our care. So I hope this lecture made sense. I hope you liked it. If you did, make sure you like it, leave a comment down below. Don't forget to check out ninjanerd.org. That's where we have all of our notes and illustration for every lecture that we put up here. And as always, until next time.